But anyway, I really want to thank you, Bill, for inviting me today. And I have been doing research for 40 years, clinical research. And I was on faculty at Rutgers for a number of years before I came to UNM, and I taught research ethics there. So this is a topic that's near and dear to my heart, is to really participate in bringing information about research ethics and helping you guys think about research ethics. And this fall in the psychology department, I'm actually teaching clinical ethics to the graduate students. So my mind is filled with ethics, and so it's a nice opportunity to talk about it some more. As I said, I've been doing research for 40 years. My 40 years of career has all focused on clinical research with clinical populations. And from talking to the first half of the class who got here early, it's apparent to me that clinical research is not what you guys do. So in the course of this talk, I'm going to start by hoping that the slides will advance. Let's see if it will do it this way. Hit page down, so that didn't work. There we go. Okay, it's moving slower than I am. It's the curse of my life. Anyway, so I'm going to start with giving you some overview of what clinical trials actually are and some of the really research features that are involved with clinical trials. Then I'm going to tell you about a study that we're actually conducting right now with a prisoner population. And then I'm going to go through in a systematic way some of the ethical issues that I think we encounter in conducting clinical trials, and conclude with a few personal thoughts about this whole enterprise. I hope that this will be interactive. There are going to be places where I'm going to actually have a slide that says, what are your thoughts? And so then I really hope that you'll share your thoughts. But any time during this, as if you have questions or comments, please feel free to interrupt. I can talk almost incessantly. So don't worry, that you're like, oh my gosh, I don't want to interrupt her or something like that. Please do as you have thoughts, because the idea of this is to really engage your brains and helping you learn to think about these kinds of issues, which I think are probably different than what a lot of people's experiences are. So as I said, I invite you to be involved with the conversation.
Space bar. Oh, there. Oh.
Let's try a space bar. Okay, that seems to work. Okay, just for fun throughout the talk, I have little icons that will tell you which of the major research ethical principles different slides are referring to. So starting up here, you will see, it's a little hard to see here, but this is a goldfish jumping from a completely plain little goldfish bowl to one that's got plants in it. And that for me was a nice symbol of respect for persons and their autonomy, because he got to pick which bowl he wanted to live in. Beneficence, this is actually a statue of an angel at Ball State University, which represents beneficence. The scales of justice are pretty straightforward in terms of that principle. The principle of trust is the mountain climber, or the person who just fell off of the mountain and their friend is helping them back up. And then scientific and integrity and fidelity was actually the hardest one to find a little Google image of. When I first did integrity, and I got lots of things that actually had the word integrity. When the technical people in the room will appreciate this, when I tried Googling scientific fidelity, I got pages and pages of different kinds of speakers, high fidelity speakers. So those are the symbols that you'll watch for, and it'll help you kind of guide your thinking and hopefully make it a little bit more interesting. Okay, so I'm going to first talk, as I said, some about what is a clinical trial, what are some of the design features of clinical trials, what are the sort of hallmarks of them. At the end of this part of the talk, I'm going to ask you to share your thoughts about as you listen to this, what you think are some of the ethical challenges in conducting clinical trials. So as I'm talking, please be thinking about that, because I'm going to ask you to share some of your thoughts. Okay, so let's just start with what is a clinical trial. Basically, a clinical trial is a controlled study to test a treatment or an intervention for a specific problem. Many people are familiar with medication trials, with placebo double-blind placebo trials, things like that. But there also are lots of clinical trials that aren't medications, that they're studying a specific kind of treatment. We usually talk about two different kinds of clinical trials. The first are what are called efficacy trials. More recently, they've been called explanatory trials. But efficacy trials are designed to give your treatment, whatever it is, the very best test possible under the most optimal conditions. So in an efficacy trial, you're trying to control as many extraneous variables as you possibly can. So for example, if you have a new treatment for alcoholism or alcohol use disorders, you might not want to just recruit a sample of anybody with an alcohol use disorder, because 50% of them are going to have depression or anxiety, and 45% of them are going to be using other drugs, and they're going to range in age from about 14 to 84. And so you have lots of heterogeneity in your sample. If you want to test your treatment, you tend to you try to exclude as many of those extraneous variables as possible. So that's an efficacy trial. If you have a treatment then that works well in your efficacy trial, eventually you want to say, does this work under real world conditions? And then you're conducting an effectiveness or a pragmatic trial. And there you kind of take off many of the controls in terms of the sample and the setting and those kinds of things, so that you have a more generalizable trial. And if you get good results with your efficacy trial and your effectiveness trial or your pragmatic trial, then you can say, oh, maybe this is actually something that ought to be used in the real world. But those are the two types. I'm going to focus mostly on efficacy trials simply because there's not enough time to talk about both of them. There are lots of other designs to test treatments also that I'm not going to talk about, but just to keep this kind of under control. But this is a really good exemplar of how you actually do clinical research. Okay, so lots of things about how to really design a clinical trial in a way that's optimal. Starting with, as I implied in talking about the last slide, that the population that you're studying is very carefully specified. So you decide who you're going to include and who you're going to exclude. An example, as Bill mentioned, I've done a lot of research with couples, and we've tested therapies for couples together. One of the things that we know is that many couples experience intimate partner violence or domestic violence. If it's severe, it's really considered inappropriate and unethical to treat people together, because you put them in the same room and they talk about problems that are concerning and upsetting, and then they may go home and there's abuse that occurs at home. So that's an exclusion criterion. But again, it cuts out some of the people who may be experiencing these problems. Lots of other reasons you would include or exclude people. We also standardize the procedures we use to recruit people and screen them, so that everybody goes through the same process right from the beginning. You use standardized measures that are validated to actually screen people. Obviously, we obtain informed consent from participants to be in the study. The treatments that they're going to receive are very, very carefully specified. So typically, you have a treatment manual that guides what the therapists are going to be doing in the study. And if you're comparing two active treatments, you have 2 treatment manuals, or you have 3 treatment manuals, or whatever. But the treatments themselves are very, very carefully defined. If you have comparison treatments, you may be comparing the treatment you're really interested in to no treatment, or a placebo treatment, or treatment that's just what's usually provided, or some other kind of experimental treatment or treatments. So you're being very specific about what are you comparing your treatment to. Okay, participants are randomly allocated to the treatment conditions. You don't say, oh, I think this person would really do well in this treatment and this person would do well in this treatment. You randomly assign them. Sometimes you counterbalance them on specific variables that you think might affect outcomes. So basically, they're randomly assigned. Before they're even assigned to a treatment, though, you collect the baseline data because you don't want to bias the data in any way. It might be that if the participant knew what treatment they were going to receive, they might answer questions a little bit differently, or the researcher might ask the questions a little bit differently. And again, using standardized, validated measures for that baseline assessment. You train the clinicians like crazy, and then you monitor them. You often listen to, if you're doing a psychological or psychotherapy kind of study, you may be recording their sessions and, doing ratings of what they're doing to make sure that they're doing it the way you want them to. You supervise them. So they get really, really well trained and they're really well supervised, unlike your average clinician in the community, I might say. The participants are filling out questionnaires and answering questions during treatment, and they're being followed over time. In alcohol and drug treatment studies, the standard really is that you follow people for a year after the treatment is over, and you pay them to get in the study. Yeah?
How do you go about following them? Because I'm looking at what you're doing, and a lot of it has an impact methodologically on what I'm doing in terms of education research.
Oh, okay.
And,
okay. Interesting.
One of the things that the study I'm working on lacks, but the new one I'm hoping will have, is a longitudinal component. But we haven't quite figured out the logistics of following someone around.
It's an art, I will tell you that. It's an art and a science. So there are a bunch of things. First, obviously, in the consent, they have to be they're told that they're going to be followed and they're going to keep in touch with them, so they know it from the beginning. You have a schedule for follow-ups and a compensation schedule. Yeah. Okay, so let me tell you about a study that we're doing right now. And this study is funded by the National Institute on Drug Abuse, or NIDA. We are the subcontractor to UCLA on this study. So I only say that because I did not pick the name of the study, and there's one design feature that I don't love. But it's called Injectable Pharmacotherapy for Drug Abuse, or IPOD. And just to let you know, why are we doing this kind of a study? When you look at our jail and prison populations, a good 60%, 70%, depending on the jail or prison. But the majority of people who are in there have substance use or alcohol problems, or both. Do people know the difference between jail and prison? Not everybody would know that. Okay, some people do. Do you want to say, or should I just say? Okay, so jails are short-term incarceration facilities up to through 364 days. People aren't supposed to be there for more than a year. When people are arrested, they typically are taken to jail. The jail in our county is the Metropolitan Detention Center, or the MDC. And so people are there pre-trial. People tend to be kind of in and out of there, so they may be arrested, and a few days later they make bail and they're out. Some people are sitting in there until they're tried because they have no money or nobody who can help them with bail. People also will be there after they've been sentenced if they're in there for shorter sentences. People who've been on probation and violated their probation by doing something they weren't supposed to do may come back to the jail because of the probation violation, and then there's another court process. So the jails are a very heterogeneous kind of population. Prison tends to be people who've been sentenced to longer terms than a year. And so, when you think about prisons, those are people who are going to be in there for a while. Okay. So that's sort of what those facilities are and the kind of overall issues around drug issues. A very specific population, the population that we're studying in this project, are people who are opiate users. We know that, and there's some really scary studies out there that show what happens. Somebody comes into the jail and there's not much to help them detox from the opiates. They get what's called a kick kit, which is a few very, very low level medications and some support, but they really don't get much of anything. But eventually, since they're not getting opiates, most of them, they go through the withdrawal process, and then they're in there for a little while. The average length of incarceration at the MDC is about 150 or 160 days. So they've been in there for a while. They've lost all their tolerance to the opiates. They've gotten no treatment of any sort. They leave the jail, and some of them go out and they score more drugs. and so they may take the same amount that they had been using before they came into the jail, and they overdose. And the death rate in that first month after release from jail is about 12 times the death rate for people in the next 11 months out of jail. It's a really, really high-risk, dangerous period for people. Right now, there are 3 medications to treat opiate dependence. One is methadone. That's the one that people are most familiar with. It also is an opiate, but it's long-acting, and so people can take it once a day. You don't get high from it unless you take a lot, and so people can come and get their dose of methadone once a day and function pretty stably. It's a very good medication. Suboxone or buprenorphine is a mixed medication. It does a couple of things, but partly it binds to the opiate receptors in the brain, so if somebody takes an opiate, they don't get a high from it. Those are prescribed in physician offices. They've tried using buprenorphine or Suboxone in jails, and you do get a bit of a kick. You can get a kick from it if you use it inappropriately. And there's, in like Rikers Island in New York, there's been at least one study showing that there's like a big underground trade in buprenorphine, so the jails hate it because it's yet another drug that people use in the jail. The third is naltrexone, or an injectable form of naltrexone called Vivitrol. And this is, it's an opiate antagonist, and it completely binds to the opiate receptors in the brain, so that if you take an opiate, nothing happens. Okay. Trouble with naltrexone is it had been only an oral medication. You take it once a day, and so if you want to use, you just don't take the naltrexone, and then you can get high. The Vivitrol is great. That's the monthly injection in the butt, and once you've had the injection, your opiate receptors are blocked for a month. So it's kind of a cool medication. It really has hardly been tested in these populations. Yeah.
Listen, that all of the ones that are like blocking the receptors,
Mm-hmm.
you still overdose on those?
Mm-mm.
Can't overdose.
Mm-mm.
It prevents that.
Mm-hmm. Yeah, that's why it's such a cool drug. Okay, so what are we doing in this study? And then this is going to be my second time I ask you a question about what do you see as issues with this. We're recruiting opiate-dependent inmates from the MDC, who we start the recruitment when they're within a month of release. And we randomly assign them to one of 3 treatment conditions, or 3 conditions. The first is treatment as usual, and at the MDC, treatment as usual is no treatment. We're doing a little more than that because we're doing some drug education with them, particularly to alert them to the danger, the lower tolerance and the risk for overdose when they're released. But it's basically a very short kind of education intervention. The second condition is the Vivitrol injections, and we do the first one within 2 weeks of the time they leave. They're supposed to leave the jail, and then they get 6 more Vivitrol injections over the next 6 months. Plus medication management visits with a physician every 2 weeks for the first 3 months, and then once a month after that. And then the third condition includes the Vivitrol with the medication management, and then what's called patient navigation. And it's a really interesting part of this design, because many of these folks, as they're getting out of jail, don't have jobs, they don't have a place to live, they're not on Medicaid. They may have children, particularly women, and they may be going back, have lost custody of their children, or their children are somewhere and they're going to try to reconnect with them. They don't have job skills. They really are, they're a very, very impoverished population in all sorts of like social ways. So the patient navigator position is to help a person, the people in this treatment condition, to navigate their lives. So the patient navigator meets with the inmate before they're released from the jail, and then kind of says where are your needs, and then helps them with hooking up with housing, emergency housing, hooking up with emergency food stamps, helps them apply for Medicaid if they need to do that, and so on. And our patient navigator has this huge kind of body of information now about resources in the community. Okay, so that's the design. We do all the initial stuff at the MDC. and then we follow them medically in one of 2 community clinics, and then we collect follow-up research data 1, 3, 6, and 12 months after the baseline assessment. So this goes back, coming from that specific study, to, in general, some of the ethical challenges with clinical trials. Big issues around consent, autonomy, coercion, and some of these we haven't talked about. People who are seeking, who volunteer for a clinical trial are suffering from something that's painful in their lives, and so they're looking for help. They're like, wow, it's free help in this clinical trial, and so right away there's almost an implicit coercion, because they're getting free, they're going to get free treatment for something that they're worried about, and they're going to get paid to participate. So the importance of making sure that they're informed with the consent, and that they know that they're free not to do it, and having other resources available to them is a really important part of trying to deal with that coercion. Another thing that's an issue with mental health issues and substance use issues is that many of those impair reasoning and judgment and decision making. And so even though they're legally competent to give consent, you have an extra responsibility to go through and make sure that they're understanding what they're agreeing to. And some people have actually been coerced. They've been told they have to seek treatment. Their probation officer has told them that, or their boss has told them that, or their spouse has told them that. And so again, you have to help them separate out, I have to get treatment, from I have to get treatment in this study, in this research study. So that all those are sources of coercion. And then there are people who, even though they haven't been formally coerced, they kind of feel like they're coerced. Like the spouse who says, I can't stand this, I can't take this, one more time, you got to do something. Or the boss who's saying, you've come in 3 times late, and like you look awful, and you smell like booze. What's going on? And so sometimes people feel implicit coercion, even if it's not explicit. Okay. We talked a little bit about this a couple of times, the whole selection of the comparison or control groups. And so I guess somebody made this comment right at the beginning about the use of a no treatment control group if there's a known efficacious treatment. And generally in clinical trials we don't do that. You start with what's known to be effective, and you're trying to use that as your baseline to compare other things to. Deciding what a placebo is, and if you're not doing a medication study, is a really interesting challenge. I'm not sure it's an ethical challenge, but in some ways it is, because people are believing that they're going to get something. The treatment as usual I already talked about. The last thing I want to mention on this slide is the real challenge of explaining your treatments to the participants, because you need to tell them they're going to be randomly assigned, and usually you just say randomly assigned like the flip of a coin. And you don't want to create an expectancy that one treatment's like much better than the other. So you can, in this iPod study, you can tell where I think what's going to do the best. But in talking with participants, ethically, you don't want to affect the integrity of your design. That's why that one is there, by building up one treatment and then telling them another one is bad. But you also don't want to lie to them. So you have to kind of develop a way of explaining a trial in a way that they can see that there could be benefit in any of the treatments that they could get assigned to. And you have to say that in a way that's actually honest. So that's a real challenge. Okay. Inclusion and exclusion criteria, and your responsibilities to people who are excluded from the trial. So at the beginning of this class, I talked about the need in efficacy trials to have relatively homogeneous populations, but you don't want them so homogeneous that there's no generalizability. And you also don't want to systematically exclude specific groups, which is why the justice symbol is up here. So if you say, I'm only going to do a study, there was a point in the past where people did all mental health and addictions trials with men, and assumed that that was relevant to, those results would be completely generalizable to women. We know that that's not true. We know there have been many, many studies, and still true in mental health field, with primarily Caucasian samples. not particularly generalizable to African Americans or Latinos or to Native Americans or, you know, lots of other populations. So, you know, I think you're always like balancing that the research design issue against the, you know, the justice issue, which is doing research that's going to be relevant to, you know, a range of populations. What do you tell people who are excluded from the study? In a jail population or any kind of closed system, if you tell people why they're being excluded, word gets around. So, you know, if we said in the jail study, well, you know, you don't qualify for the study. Well, why don't I qualify? Well, this isn't true, but we're excluding people who had taken opiates for pain within the last 6 months, so they'd had a pain condition that required opiates. And we'd say, well, you know, you're being excluded because you had an opiate for pain 5 months ago. You know they're going to tell their friends on the unit, on the pod, you know, don't tell them about that. So, you know, suddenly, so your sample gets messed up. So typically, you know, you don't tell the people why they're excluded, but that, you know, does raise questions about that respect for persons, you know, that you're withholding information from them. So, you know, honestly, you say, well, you know, I'm not allowed to tell you the reasons you're excluded from the study, but people who are excluded, I think you have an obligation in any kind of a clinical trial to provide alternative referral sources for them, so that they have some. So you can say, I'm sorry, you know, you don't qualify for this study, but since you're looking for help for, you know, your depression, here are some resources in the community that could be helpful to you. Now, I will say, some people do not like that. Going back to my couples therapy studies where we've excluded people where there was, you know, really high levels of domestic violence, and we had one couple who was so angry at us, and they were like, no, we want this treatment, we really need this treatment. And we were saying, it's great that, you know, you really want to change. It was a woman with a drinking problem and her husband, but this is not the right treatment for you. You know, it's not the standard of care. We didn't say that, but it's not the right thing to do for you. And here's some other ways you can get help. We had so many conversations with them because they, you know, all those other things. They were desperate. They needed help. They thought this was a way to do it that wouldn't cost them anything. And but we had to say no. We had to maintain the integrity of the study and protect their safety. But it's not that easy. Sometimes it's not that easy to exclude people. It seems like a simple thing, but it's not. Yeah. Okay. Let me just talk about measurement for a minute. In psychologists, and I think sociologists are this way as well, love to collect data. We want to know about many, many, many things. And for many years, clinical trials would have participants be there providing data for like 4 to 8 hours. I mean, unbelievable. You have great data, or not just like great data, but a lot of data. But you know, I think you have to balance that against that's really burdensome and painful for people to, you know, because you're asking them lots and lots of questions about things that are personally meaningful and difficult at times. So, you know, I think that's both a justice issue and a respect for persons and their autonomy kind of issue that you're needing to balance those. A second thing is selecting measures that are appropriate to the population. So the literacy is one that you've been pointing out, but things that are relevant for the person's gender, race, ethnicity, age, reading ability, you know, that all of those things, if you want to make sure that your results are meaningful, you want to have measures that are relevant to the population. And some questions and measures have impact on the participants, so you know, you need to have some preparation for that. Some things are upsetting and distressing. And also, just from a design point of view, sometimes assessment actually impacts outcome. So certainly in the alcohol field, there's actually a whole cute, neat little literature that shows if you simply assess people, they often decrease their drinking, because you're asking all these questions about their drinking and the problems it's caused, and it kind of gets a whole process going. So it's more a design feature than an ethical issue, but one that I just thought I'd throw in there. Okay, randomization. I've talked a little bit about explaining randomization. I cannot tell you how many times I've had, after going through this careful explanation, I have no control over which treatment you're going to get. Here are the two treatments. It's just like the flip of a coin, but we do it on a computer. And so, you punch in the thing in the computer, and you say, but just before you do that, the person's saying, well, I know you said you don't have any control of it, but could you please make sure that I get, and we've done a couple studies where we're comparing couples with individual therapy, and both the partners have agreed to be in the study and agreed to participate, and then they get randomized to the couples therapy, and they're like, oh, okay, we're really not interested. The non-affected partner says, I didn't really want to come. I figured it was 50-50, so you're like, but then the investigators often develop these hopes, like, oh, I really hope this comes up this way. And, ultimately, you got the randomization. If it's computer-based, it's a little harder to game the system. But, that maintaining the integrity of the randomization is really important. And they're both participant and researcher things that affect that. Okay, I already talked about participant interventions or participant preferences. The question that you raised quite a while ago about the control of the actual intervention comes back up here. You have people, the therapists know what they're supposed to do and they're being monitored and supervised, but people come in with their own needs and problems. And so you're balancing that, wanting to do no harm and be helpful to people against the scientific integrity of the study. I know I'm going through this fast, but I'm hoping that that's okay. Deterioration or lack of progress during treatment. You need to monitor that. Goes back to your question before about making sure that you know how people are doing, and you have a responsibility with more severely impaired populations to actually define your standards in advance for markers of deterioration or lack of progress, and have a procedure that may mean that you're going to pull them out of the clinical trial to make sure that they get the appropriate services. But you want to have, you need to have some way to plan for that and anticipate it, because mental health and addictions populations don't all get better, unfortunately. Okay. Deterioration during follow-up is a little bit different issue. So if you're if you're done with all the treatment and now you're following them, and the research interviewer hears that somebody is doing poorly, you're on the kind of horns of a dilemma, because really what you're trying to do is evaluate the outcomes. And if some people are doing well and some people are doing poorly, as a scientist, you say, that's good because I have differential outcomes. As a responsible clinician and as a human, you're like, that's bad. So we try to make sure that the research interviewers always have a list of referrals, and if a participant says, I'm having trouble, I need some help, then we give them the referral information. Okay. Biases are there for the researchers and for the therapists that they're different. We often will think, oh, this person is perfect for this treatment, or this person's not going to do well. I just know they're going to have a bad outcome, and it's tempting to say maybe we'll just exclude them from the study completely. So there's a lot of having the controls in place to balance those two things to maintain the integrity of the study. Okay, the last two slides. The first is the researchers and the therapist hearts. As I said, I've been doing clinical research for 40 years, and I do it. I'm a trained clinical psychologist. I got into this field because I cared about individual human beings and their suffering, and I've been in the addictions field all of that time. And I do this because I want people to get better, and I want my science to generate better knowledge, knowledge to help more people get better. But it's a dilemma when you see somebody who's, not that they're deteriorating or anything terrible is happening, but they're not doing that well, and either in the during the clinical trial or during the follow-up, and what you wanted, your heart says, well, I want to do more, and your scientist brain says, I can't do more. And so there's that balancing that's really, really, I think, difficult in doing clinical research. That's different than other kinds of research. And in many of the clinical professions, one of our ethical obligations is first do no harm. And so you need to have that kind of awareness as a clinical researcher that you can't do harm, but you can't always do help. Okay, I'm going to skip that because I'm guessing you talk a lot about confidentiality in here. Okay, and just the final thing, I've said part of this already, but clinical research is really challenging. You're working with human beings who are often confused, distressed, upset, have chaotic lives, can be incredibly annoying sometimes. You're like, why don't you just come in for your research follow-ups, or why don't you answer the telephone or return my calls? And just that there's that frustration piece that's different than other kinds of research. And as I said, there's that desire to I always actually wish that every person in my clinical trial would do well, and that's not my scientist hat that's there. And I think what's kept me in this field is I've seen real progress, from science, from clinical science, in developing better approaches to treatment for people with a range of mental illnesses, with substance use disorders, and the kind of tension that I experience as a clinical scientist. I've been able to tolerate it because I really do. I've seen progress over these 40 years. Not just in my own work, but in general, and what we can do in these fields. And it's kind of what keeps me going, and trying to keep figuring out how to do this in a way that's fair and respectful to the individuals, and that's done in an ethical way. So that's my personal reflection at the end. So, oh, thank you.